Welcome to Bit by Bit Pedagogy. Today we are tackling a giant of the USMLE in clinical psychiatry, the schizophrenia spectrum. We are going to deconstruct this complex pathology bit by bit. By the end of this session, you won't just be memorizing symptoms. You will understand the hardware, master the software, and know exactly how to pivot when the NBME timer tries to trick you. Let's dive in. To master this spectrum, we need to view it as an operating system. First, the hardware, the physical neurobiology, and the 4 dopamine tracts. Second, the software, the temporal criteria. The timer is your best friend on the exam. Finally, the tools, our pharmacology, typicals versus atypicals, and how to manage the emergencies they cause. Module 1 is the hardware. Before we talk about hallucinations or flat affect, you have to map the 4 dopamine highways in the brain. Every single symptom of schizophrenia and every single side effect of our drugs maps perfectly to one of these 4 tracts: Mesolimbic, Mesocortical, Nigrostriatal, and Tuberoinfundibular. Remember about the biochem tie-in here. Phenylalanine yields tyrosine, which yields dopa, which then goes on to produce dopamine via dopa decarboxylase, requiring vitamin B6 as a cofactor. A mechanism of action tie-in here is that dopamine is degraded by MAO and COMT into homovanillic acid. First up, the Mesolimbic tract. Remember this rule. Limbic is loud. This is the pathway responsible for reward, emotion, and addiction. In schizophrenia, this tract is hyperactive. There is simply too much dopamine firing here, which generates the noise, the positive symptoms like auditory hallucinations and paranoid delusions. Our therapeutic goal is straightforward. Block the D2 receptors here to silence that noise. This tract runs from the ventral tegmental area, VTA, to the nucleus accumbens. A pharm tie-in here is that cocaine and amphetamines increase dopamine in this exact tract, which is why substance-induced psychosis perfectly mimics positive schizophrenia symptoms. Next is the mesocortical tract. If limbic is loud, cortical is cold. This tract governs executive function, motivation, and logic. In schizophrenia, this pathway is actually hypoactive. There isn't enough dopamine. This dopamine deficit gives us the negative symptoms, the 5 A's: flat affect, alogia, avolition, anhedonia, and poor attention. Now, look at the catch-22. If we give a typical antipsychotic, we block D2 everywhere. We fix the loud limbic system, but we further freeze the cold cortical system, often making negative symptoms worse. Remember, this tract runs from the ventral tegmental area, VTA, to the prefrontal cortex. Beyond dopamine, remember NMDA receptor hypofunction in the cortex contributes to these negative and cognitive symptoms. This is why NMDA antagonists, like PCP and ketamine, cause schizophrenia-like states. Our last 2 tracts function perfectly normally in a baseline schizophrenic patient. They only become a problem because of our interventions. They are iatrogenic casualties. When our D2 blocking drugs hit the nigrostriatal tract, we induce Parkinsonism and extrapyramidal symptoms. When they hit the tuberoinfundibular tract, we remove the brake on prolactin, leading to hyperprolactinemia. Dopamine is prolactin-inhibiting factor, PIF. Blocking D2 receptors on lactotrophs in the anterior pituitary allows unchecked prolactin secretion. Prolactin then inhibits GnRH, leading to decreased FSH-LH, causing amenorrhea, infertility, and osteopenia. Module 2, the software. This is where you get your points on test day. The boards will give you a patient with auditory hallucinations and disorganized speech. The symptoms won't give you the diagnosis. The timeline will. Burn this mnemonic into your brain. 1-6, Psych. Less than 1 month is brief psychotic disorder. 1 to 6 months is schizophreniform. Over 6 months is full schizophrenia. Now I would strongly advise on test day, or whenever you are doing questions for this, to highlight the timeline. This will help streamline your thinking into the major players with regards to schizophrenia. Brief psychotic disorder is a short-lived stress blip. It lasts more than a day, but less than a month. It usually follows a massive psychological stressor, like a sudden death in the family or severe trauma. The defining discriminator here is that once the episode clears, the patient returns completely to their normal premorbid baseline with no residual deficits. Also, postpartum onset is a classic highly tested variant. If a woman develops frank psychosis 2 weeks after delivery, it's postpartum psychosis, a psychiatric emergency due to infanticide risk, falling under this timeline. If the timer crosses the 1-month mark but hasn't hit 6 months, you are in the schizophreniform placeholder window. Form means it is forming into schizophrenia. While functional decline isn't strictly required to make this diagnosis, the clinical reality is that about 2/3 of these patients will eventually cross the 6-month threshold and require a permanent re-diagnosis. Good prognostic factors for the spectrum include acute/rapid onset, later age of onset, female sex, presence of positive rather than negative symptoms, and no family history. Once we cross the 6-month mark, we arrive at chronic schizophrenia. This requires a marked functional decline. They've dropped out of school or lost their job. Let's look under the hood. Anatomically, you'll see enlarged lateral ventricles due to cortical tissue loss. Genetically, it's highly heritable. And a crucial warning, these patients have a 10% lifetime risk of dying by suicide. Schizophrenia is highly polygenic, but interesting research has shown the C4 gene from the complement system involvement can lead to excessive synaptic pruning during adolescence, which can increase the risk of schizophrenia development. This slide right here is worth pure gold on the exam. How do you tell a primary psychotic disorder apart from a primary mood disorder? You use the 14-day rule. For schizoaffective disorder, the patient must have at least 2 weeks of frank psychosis in the absolute absence of any mood symptoms. If the voices only happen when they are severely depressed or manic, that is a mood disorder with psychotic features. Remember, if the baseline is psychosis and mood episodes occasionally visit, it's schizoaffective. If the baseline is mood and psychosis only visits during the deepest valleys or highest peaks, it's mood with psychotic features. Don't let the similar-sounding names trip you up. Delusional disorder involves a fixed belief, but their daily function is entirely normal. They can hold a job and interact normally until you bring up the delusion. For the personality disorders, schizoid patients avoid others. They are content being alone. Schizotypal patients are a type of weird. They have magical thinking and odd behaviors, but no frank, fixed psychosis. Just to add in, personality disorders, cluster A, are egosyntonic, lifelong patterns of behavior, whereas schizophrenia represents a distinct break from reality. Moving to Module 3, Pharmacology. Our typical agents are the original D2 sledgehammers. High-potency agents like haloperidol bind D2 tightly, giving us excellent control of positive symptoms, but a very high risk of extrapyramidal symptoms, EPS. Low-potency agents like chlorpromazine don't bind D2 as tightly, but they bind everything else: histamine, alpha-1, and muscarinic receptors, giving us the classic ham side effects like sedation, orthostatic hypotension, and dry mouth. Something I always struggled with is volume of distribution, and these drugs are known to be highly lipophilic with a large volume of distribution, VD, allowing them to easily cross the blood-brain barrier. Also, chlorpromazine causes corneal deposits. Thioridazine causes retinal deposits. Key pearls like these can help you pick the correct drug on test day. Atypical agents are the modern standard of care because they offer a dual-action pivot. They provide moderate D2 blockade, but they add serotonin 5-HT2A antagonism. Why does this matter? By blocking 5-HT2A, we actually increase dopamine release in the prefrontal cortex, which helps treat the negative symptoms that typicals ignore. Plus, the looser D2 binding means a much lower risk of EPS. Serotonin normally binds to 5-HT2A receptors on dopaminergic neurons to inhibit dopamine release. Antagonizing this receptor cuts the brake line, letting some dopamine flow back into the cold cortical tract and the nigrostriatal tract, which mitigates EPS. Atypical antipsychotics reduce extrapyramidal symptoms through stronger 5-HT2A antagonism, but many come with major metabolic side effects. Olanzapine and clozapine carry the highest risk for severe weight gain, dyslipidemia, and insulin resistance. Risperidone is notable for hyperprolactinemia due to dopamine blockade in the tuberoinfundibular pathway. Ziprasidone is classically associated with QT prolongation. Clozapine is the most effective antipsychotic for treatment-resistant schizophrenia and severe suicidal ideation, but it is reserved because of a granulocytosis. It can dangerously reduce neutrophils, causing life-threatening infections. Patients require REMS enrollment with routine CBC and ANC monitoring. Remember, ANC below 500 equals a granulocytosis. Clozapine also lowers the seizure threshold and can cause fatal myocarditis. On exams, a patient on clozapine with fever, sore throat, recurrent infections, or neutropenia should immediately make you think clozapine-induced a granulocytosis. When a patient taking antipsychotics develops abnormal movements, the key discriminator is timing. Use the mnemonic ADAPT to memorize the extrapyramidal symptom timeline from hours to years: acute dystonia, akathisia, Parkinsonism, and tardive dyskinesia. Boards constantly test both the movement disorder and the onset window, so memorize the chronological order cold. Mastering ADAPT. Acute dystonia occurs in hours to days and is treated with benztropine or diphenhydramine. Akathisia, days to weeks, causes restlessness and is treated with beta blockers or benzos. Parkinsonism, weeks to months, is treated with benztropine or amantadine. Tardive dyskinesia, months to years, involves chorioathetoid movements and is treated by switching to clozapine or with valbenazine. Neuroleptic malignant syndrome is a life-threatening emergency caused by severe dopamine blockade. Look for fever, autonomic instability, elevated CK, altered mental status, rhabdomyolysis, and classic lead pipe rigidity with hyporeflexia. Stop the antipsychotic immediately. Treat with supportive care, IV fluids, dantrolene, or bromocriptine. Dantrolene blocks calcium release from the sarcoplasmic reticulum through the ryanodine receptor, reducing muscle contraction and heat generation. Differentiate NMS from serotonin syndrome, which presents with hyperreflexia and clonus. A 24-year-old hears voices for 4 months and stops attending classes. Step 1. Identify the schizophrenia spectrum lead-in. Step 2. Find the pivot point. The timer is 4 months. Step 3. Lock in the discriminator. Greater than 1 month but less than 6 months equals schizophreniform disorder. Do not get distracted by functional decline. The timer is the true discriminator. A 30-year-old has depression with psychosis for 2 months, but years earlier had psychosis for 4 weeks without mood symptoms. The key discriminator is psychosis occurring independently of mood episodes. That fulfills the 2-week rule for schizoaffective disorder. Boards often present these patients during depression to bait you into choosing major depression with psychotic features. Always ask whether psychosis has ever occurred outside mood episodes. A patient switched to fluphenazine now paces constantly and cannot sit still. This is akathisia, an extrapyramidal side effect from a high-potency typical antipsychotic. The key discriminator is severe inner restlessness with pacing. Treat with a beta blocker like propranolol. Do not mistake akathisia for worsening psychotic agitation. Increasing the antipsychotic dose usually makes the symptoms worse. Before the exam, make sure you can map all 4 dopamine pathways. Apply the schizophrenia timer system. Recognize the 2-week rule for schizoaffective disorder. Differentiate high versus low-potency antipsychotics. Remember clozapine monitoring. And recite the ADAPT extrapyramidal symptom timeline from memory. Pause and actively recall each concept without looking. System complete. Remember the core principles. Think mechanism, find the pivot point, and trust the discriminator. The transition from step 1 into clinical rotations is about recognizing these mechanisms inside real patients. Every psych patient on the wards reflects the same dopamine pathways, timelines, toxicities, and pharmacology you studied today. Thank you for studying with Bit by Bit Pedagogy, and good luck on your exams and rotations.